speaker, Dr. Arvind Diwaker Jain, who will be speaking to us on the humble hypodermic needle. However, Dr. Diwakar has purchased a new phone where he's having some trouble with his hotspot, and so he has gone to his neighbor's house to get a hotspot, and he'll be delayed by another 5 minutes. Please bear with me patiently, and he will be with you for his wonderful long-awaited lecture. Please be patient for another 5 minutes. He's joining us. Thank you. Yes, Dr. Diwakar has found his signals and he's back in action. I'll spotlight him and ask him to unmute. So I will just introduce, his video is off. Dr. Diwakar, can you unmute your audio? Or is the signal again on, off? Yes. Your net is cutting and going and again cutting and coming back. Can you unmute?
From your side.
Can you unmute? Unmute, yes.
Hello, can you hear?
Your,
Yeah, I have unmuted.
your net is very, very slow.
But even I have bought 2 connections, both are not working. 3rd connection I have taken.
Let us hope it works. In case there are any problems, I will play the slides and you can just do the audio.
Can you hear me?
Yes, I can hear you very clearly. Dr. Diwakar, you seem to have gone back again offline. Let me get back to gallery view. Now your connection seems to be better, Dr. Diwakar. Can you hear me? You are muted. You have to unmute.
Okay, now. It was muted from your side actually. So I could not unmute it. Now can you hear me?
Yes, clearly, very clearly.
Can you hear me?
Yes, we can hear you.
Okay, now shall I share my screen now?
Yes, you can start sharing your screen. In case any mishap happens, I will take over and start sharing the other screen. All right?
You enable my screen. It is
Yes.
from your side.
Yes, one minute. Because of this problem here, we had some minor issues. 1 minute. Oh, shit. What is this? You have to wait 1 minute. One second. There we go. Uh, 1 minute. Make co-host. Yes. Now you see if you can share your screen.
Yes, yes. Now the screen is showing.
Wait.
My screen is showing.
No. Yes. It is very slow. So I suggest that I put the slides and you just do the speaking. That way it will be easier.
Okay.
Yes, 1 minute. I'll
Okay.
share my screen and you just need to speak. Because much easier for me to play from here than yours. Is it visible now? Dr. Diwakar, are you there? I think he's still having some small trouble in his internet. However, I hope the members are able to see it properly. And there we go. Good morning, Dr. Patel. Can you hear me? Can you hear me?
Yes.
Good. Dr.
Go
Jain,
ahead.
some small internet problems. So he's reconnecting. He's just connected. Again, he got disconnected. Now he's connected on two machines. Let us hope which one works. Whichever works.
अदृश्य रहकर शिव जी को श्रृंगार करने के लिए काशी राज की पुष्प वाटिका से
There we go. Now you have to unmute. One minute. Yes, unmute, please. Unmute.
Okay. So now I think I can see and connection is something better.
And
So
in
now
any case, I am going to run the slides, so you don't need very good connection. You just need to be speaking well, that's all.
Okay, so now let us start with the new micro-invasive technique. Because you must have seen many approaches, and this is micro because it is almost atraumatic. What happened? Last time I have told you, when we have learned that the microflora over the skin is highly resistant to the commonly used antibiotics. So it is our duty to stop surface microflora to enter inside the tissues. And this happens happens whenever you are using thread.
अरे जूम पे लेक्चर
Whenever you are using thread or catgut, thread is having capillary action and it sucks fluids from outside along with the microflora inside the tissue layers and exposed to the highly resistant antibiotic, and which is facilitated by the common antibiotic we are giving, but doesn't allow normal bacteria to develop, and it allows only those bacteria to develop. Are you hearing me?
Yes, yes, you are clear.
So it allows only those bacteria to develop which are highly resistant. Because of the antibiotic we use, simple bacteria don't develop there. So I thought I should use some suture material which is not conductive to the
I think Dr. Diwakar has disconnected. Doesn't matter, he will reconnect and come back to us. So this basically was described by him on social media about 5 to 6 years ago. The principle is simple, that unlike a nylon or a proline or a vehicle suture, which leaves an open channel between the deeper tissues and the epidermal flora containing the staph aureus, which is resistant to most antibiotics, if we convert or substitute needles for suture material or thread, the results for patients are far superior. Unlike staples, which are not hollow inside, thin hypodermic needles have the distinct advantage of not only being cheap, easily available, in abundance, in sterile condition, in all parts of the world, but are also very easy to convert into something called needle olive, meaning we can break the plastic nozzle which is used to inject or used to connect it to the syringe and use the detached bits for whatever purpose we have desired or decided to use them. In case Dr. Diwakar doesn't get online soon, I will continue on with the talk, though I may not be able to convey as much as he has desired, because all the work has been his and the slides are his. My personal experience with this is just 2 or 3 hand injury cases which did spectacularly well, but my experience is not as extensive as his. He has purchased a new phone and probably having some hotspot issues with that. And today, the internet in his town seems to be very, very slow, which is causing this problem. Skin sutures are dangerous in devitalized fingers, meaning whenever there is vascularization is affected, you will find that it causes necrosis. Tighter sutures actually strangle and cause gangrene. We have seen many fingers which would have been alive at the time of suturing subsequently becoming black and gangrenous because of vascular strangulation by sutures. primary health centers, smaller hospitals, peripheries, where such suturing is normally done by the ward boy or compounder, soon haphazardly using thick, bulky stitches, often causes such what do you call devitalization of the fingers. Dr. Diwakar is just connecting to his audio, and 1 minute, I'm making him a co-host again, and Diwakar, connect to your audio. There's some small problem with your audio, Dr. Diwakar. You're not able to connect to your audio. Well, again, he has gone offline, so it is a little tricky. Let us get back to the talk. You can see that how a healthy skin, which would have otherwise survived, gets gangrenous, necrosed, and will eventually slough because of such tight, haphazard suturing. On the contrary, you can see another case here where, because of inadequate and improper treatment, bulky bandages, lack of oxygenation, betadine, Savlon, and other toxic substances, major portion of the hand and fingers get sloughed. This is a disaster in making, because as an orthopedic surgeon, we must understand that the hand is one of the most important organs of the body. The patient faces the hand every day. Hand does almost all the functions of your day-to-day living, and it is essential that hand injuries are treated with great and intense efforts to ensure that the final result is somebody. All new participants, please mute your mics. Please mute your audio. I asked Dr. Diwakar to unmute. So, this sort of situations generally are not good. You can see that whenever you put a mattress suture, you are going to strangulate this area here and this area here between the two pink arrows. So, in the process of approximating the edges of the skin, you are actually strangulating the area that you have pinched. Dr. Diwakar, are you there?
Actually, I have connected from my mobile. I had some laptop malfunction. Actually, it was not internet. So laptop is recharging again.
Okay.
I can hear you. I can speak now. If
Yes,
you
continue.
if you allow.
It continue, please. Your talk.
So there.
Shall I go back?
Yeah, you can see.
No, I can go back actually.
Yeah.
Let's just start from here.
You can go back. So there are some problems with the suturing, because every suture, when you tighten, it creates an avascular ring which produces the dead skin, what you are seeing. Next slide. So you see all the flaps which are already traumatic, and you suture them. So you create a tension so that capillaries do not allow blood flow, and the skin flap usually die. Next.
Slide screen
Next
is
slide.
not shared. Please share.
Yes, you see. There is death of the distal pulp finger. This could have been saved by a proper technique. Next slide. Next. Change the slide.
Back
Yes.
or front?
So you see, whenever you tighten a suture, the skin in between and tissue in between, they are compressed to produce a avascular zone. Next, a meta suture creates more avascular zone than the interrupted suture. Next slide.
Arvind, you have to be patient to wait for 10 seconds after you say next slide. Because after I change the slide, it takes about 10 seconds for it to come on the screen. Okay.
Okay, so change after every 10 seconds automatically.
Okay.
Rather.
No problem. So,
So interrupted suture, they create chain slide. Interrupted suture create less zone of the avascular tissues. Next. So you see, there are vascular ingrowth, capillary ingrowth material to the wound. And whenever you create around the wound, avascular zone, the healing is impaired. Next slide. So you see, the capillary growth is there, which we can stop by using snare-like suture. The tightening of the suture, it creates a ring of avascular zone. Scars, you see, they are very bad. And although we ortho, we don't care about the scar, but many people, especially ladies, they are highly objecting to the bad scars. Next slide. We use is scarless because we produce minimal trauma. Minimal means micro trauma to the skin. So there is no scarring afterwards. Next slide. You see the disfiguring scar by the suture. You know why this is known as railroad scar. This railroad scar is produced by the bacteria from the surface growing inside the skin. That I'll come in next slide. Okay, why this railroad is created? Because of the avascular zone. Next slide. Because of the avascular zone we produce surface bacteria which go inside. So you can see the railroad scar. Sutures passing through the mucous membrane or the skin provide a wick. Wick means just like what we use in diya. It sucks because of the capillary action. It provides pathway through which the bacteria track down. And the bacteria gain access to underlying tissues. The longer the suture remains, the deeper epithelial invasion. Along with the bacteria, there is invasion of epithelium also inside. So greater the epithelial invasion, epithelial tract remains. These cells may eventually disappear or remain to form a keratin and epithelial inclusion cyst. The epithelial pathway result in typical railroad scar formation. That's why our teachers used to recommend that facial suture should be removed on third day, not more than that. Otherwise, you are going to produce a railroad. Hence, I thought of a scarless micro-invasive technique useful in skin closure and small bone fixation. So, what I did initially, I used the needle itself, but the patient used to object that you are using needle, this is not meant for. So I started cutting the needle. And the bead you see, white color bead at the end of the needle before the hub. So I cut from there. Small olive wire. सुनो अनम्यूट हो गया ये वो हो गया मतलब ब्रेक हो गया Hello?
Yes, we can
Yeah,
hear you, but your video has gone, but we can hear
Yes,
you.
yes. So now I cannot see actually.
Your video got cut, huh?
Yes.
Audio is very clear.
Okay, okay. But I cannot see what you are projecting. Yes, I can see now. Okay. So then I have cut from the hub of the needle and create a very, very small olive wire, which is very, very sharp. Next slide. And I use this small needle. It is always 26 gauze. And this needle I have used in all my treatments. Same thing I have started using in ganglion treatment. This is almost revolutionized the old treatment, which is known as satins, in which he put a thread inside a ganglion after aspiration, and the slow infections creeping from the surface of the skin, it fibros the whole sac, and that used to give a cure. But problem was recurrent bad infection. So by needle method, it replaced old satins thread. And I had to try at least 100 cases to be sure. Next slide. For how many days it has to be kept, how it should be kept, and what else problem is there. And the beauty with this method is, before, if you do not cut into olive beforehand, you can use syringe itself as a driver. Syringe, take a syringe, use it as a driver, go through the ganglion first. Because if you aspirate the ganglion first, then you will not find place to put this needle. So you prick, or you rather gore the ganglion first. Next slide. Leave the needle there, cut from the hub to make as an ovalip. This is a method given here. Give local anesthesia. Cut needle 24G into small olive. Insert aspiration syringe first. Insert aspiration syringe first. Apply olive needle and bend after cutting the bevel. Bevel means the point of the needle is cut so that it doesn't entangle into the clothes. Convert the olive into a staple. We, with the help of artery forceps, we bend it and convert it into a small staple. Leave open or apply handy-plast washproof strip and call after a month. This, after a long trial, I have found that 1 month is the accurate time when the total healing occurs. And no medicine whatsoever. Especially you are advised not to give antibiotic, because if you give antibiotic, it may stop creeping of some bacteria which are needed to cure the ganglion. Next slide. I don't see slide now.
Wait, your connection is slow, you will see. Wait a minute. The slide reads, micro olive wire is cut from a needle. Always aspirate fluid after needle insertion. Otherwise, sac will not dry up. Can you see?
Yes, I can see now. Yes. So you, next slide, please. Change the slide.
Yes, changed.
Yes. So now you see, there is a ganglion. Insert aspiration needle first. Do not aspirate before inserting olive. You should not aspirate before. Next slide. Because once you aspirate, the sac will collapse and you will not enter. Cut the tip of needle later on, so that bevel before bending it. Next slide. These are the comments from some of the followers. Sir, I did my first ganglion treatment by method described by you, and it was on dorsum of foot. This method works very well on the foot ganglions. So kept needle for 3 weeks, and this fellow kept for 3 weeks, and ganglion had disappeared, and he doesn't expect to recur now. Patient is also happy. And then another person, yes sir, I am Dr. Atal from the Afghanistan. I put the needle for 4 weeks and now she is happy and fine. Thanks for sharing your method. So the needle prick is so small aperture that it doesn't create any lesion afterward. Final look, apply a band-aid over keep it waterproof. So you have bent the needle like a staple, olive is there. So if you don't put the bead here, sometimes it is buried inside, so it is difficult to find. So we have to leave this bead here. Next slide. If you may get buried and you'll have to give local anesthesia. Sometimes people ask that why do you keep this needle? I tell them this is the cure. It has got medicine inside it. Example of inferiority. This is a very, very good case. One surgeon has excised this. He charged heftily, gave a scar, and the pain and ganglion recurred after a month. An example of inferiority of excision and panacea of the needle treatment. And this lady, she had a very poor vertical scar, 1 month rest and antibiotic given, but recurrence as well as now we'll give it. I was just posting at that time, so I have given a safe treatment, my own method. I put the needle and the next day pain was gone. And there is no post-operative medicine whatsoever. Patient is comfortable. Now start working with the needle. And previously after the surgery, she was unable to work. And you can see later, I will show you next slide, that there was no scar from my method. So this was a very, very good comparative case that surgery is not as good. Pain relief and cure by needle in failed surgery without unsightly scar given by the excision. Next, please. And this is the final look. This is the final look. You can see my scar is a point only. Again, the screen share is gone.
No, it is there, it is there, it is there. You wait, you will get it. Your connection is very, very slow. I will read this slide for you. Need being solid.
When seeing the screen.
Are you able to see it? Again, I think Dr. Diwakar's connection has been cut. So this is turning out to be a talk given by two speakers. Very simple, needle being solid does not act as a wick and does not allow imbibing of the fluids. Now, this because the hollow portion is inserted from one side, extracted from the other side, and both the hollow ends are outside the skin, there is no wick action and there is no direct passage between the highly toxic epithelial flora and the deeper structures. Dr. Diwakar, carry on.
Yes, but I am not seeing the screen.
He's again lost connection, so let me tell you the advantages of the Diwakar needle method.
I don't see screen share.
Your phone or laptop has a problem. Come back on the phone, that is better.
Laptop is gone. I am working from phone only.
And you're not seeing the screen.
Yeah, I am not seeing the screen.
Some problem with your phone. I think everybody else is seeing the screen. I have muted everyone. Let me continue, and then when you see the screen.
Yeah, you can continue. You can continue.
So the advantages Dr. Diwakar mentions are the sharp bevel of needle is almost atraumatic. These days he uses 26 gauge to ensure that needle causes little trauma. Now, this is universal and ubiquitous because hypodermic needles are available in plenty in every clinic, hospital, or in doctor's possession. There's an ample supply of syringes and needles, always sterilized, cost less than 1 rupee in India. These needles are rather easy to cut and remove, and with the needles, you get a scarless outcome. The most important advantages are: number one, it does not constrict blood supply or strangulate like sutures. Number two, there is absolutely no tension in the skin flap. And finally, this is one of the best materials for small bone fixation because a 24 or 26 gauge wire is thinner than a 1.5 millimeter Kirschner wire. Here's an example. Is a farm injury. After 2 hours of injury in a cutting machine, the patient has come to the index surgeon. He has a dorsal transverse injury. Extensor pollicis longus is cut. The whole joint is visible, including the articular surfaces. And Dr. Diwakar thought that an open tendon repair may get infected due to suture material. Often compound dislocations get infected, and he was searching for a foolproof method in children. He repaired under ring block using needle sutures, left the wound open, did not use povidone iodine, betadine, or Savlon or other antiseptics. The wound was just washed in abundant amount of tap water. The patient was instructed to leave the finger free and exposed to the atmosphere and repeatedly wash it in running water. In just 4 days, you can see that the finger is coming up very, very nicely. Another advantage of needle is that it allows full range of motion and is extra osseous to avoid osteomyelitis. So, buddy stapling will replace buddy strapping. If you can see the radiographs of a displaced fracture of the fourth proximal phalanx base has been straightened under local anesthesia, and just by the use of needles, both straight and transverse, the two have been matched and a perfect alignment or restoration is allowed. In addition, because there are no bandages whatsoever, nor are any elastoplast bandages for body strapping, nor cloth bandages or cotton bandages, and as it is left exposed to the atmosphere, the patient is allowed or patient is capable of moving the hand to maximum range of possibility depending on the fracture, and as mobility is the most important key to hand injuries and function, these patients do exceptionally well, better than intraosseous Kirschner wires.
Now everything is fine now. I can see now everything. My laptop has been resumed. Actually, it was malfunctioning in laptop actually. Now I've resumed it. So now can you hear me clearly?
Yes, very clearly hear you.
Yes, okay now. Now my laptop was malfunctioning. So we were seeing buddy strapping for the phalanx. But the buddy strapping is not possible in compound fractures. Buddy strapping is not possible in compound fractures. Now I can share my screen even. Can I share my screen?
One minute, I just wait one minute. I'll stop share. You can share your screen. 1 minute. I stop share. Yes. Now you can share your screen. 1 minute. Let me make you a co-host. 1 minute. Make co-host. Yes. Now you can share your screen.
Okay.
You quickly run up the slides and then you highlight the one you want to show. And then yes. Now press play.
Okay.
Go to the top. Ah, yes. No. Go back.
Where is
Go up.
play?
Go
Yeah.
up. Slideshow.
Slides. Okay.
Yes. So play from current, play from current slide. Second one from left. From the extreme left, second top, just below home button. From current slide. From current, just below home. No. Just below home, there was a play from current slide. Go back to slideshow. Home, insert, design, transitions, animations, slideshow. Go back, file. Now you go to, that is it, correct.
Okay.
Click. Yes.
So there was a problem of cleaning of the wound and the maceration of the skin through the secretions. So I thought, why not make a needle to make a body staple rather than a body strapping, because the strapping will not allow you to wash and let the secretions collect. So after this, putting two fingers joining at two places usually, so that makes a body staple and that holds the fragment by single needle only. So this gives a very good cleaning, holds the bone, and allow the patient to clean in between the fingers or toes also. So now you see there is a displaced fracture. You reduce it, put a needle, and do the body strapping and keep the washing. Now you can say that why wash with the tap water? Why not with the sterile or distilled water or boiled water? The problem is tap water contains some amount of bacteria which are safe to us and potable to us rather. So these safe bacteria, they keep pathogens away from the site you are using. This is a strange principle, but as you know, if you do not sow grass in your lawn, the weeds will appear. So it is better to sow some grass, grow it. The weeds will not appear. So this principle, this was used in USA first. They are using tap water and they found tap water is more useful than the sterilized or pure water. And as Dr. Prakash was telling, I never use any chemical over the raw wound. Whatever chemical I use only on the intact skin. If the skin is open, do not damage the deep tissue by your betadine or Savlon or anything. Only chemical which is known safe to the internal tissues is 20 times diluted Savlon. That is the only known safe because it was used in bone irrigation previously. There was a thesis in our times. So in bone irrigation, we found the best concentration which does not damage bone and muscle tissue. So that is all. Even though I don't use Savlon even, I use simple water, tap water, which contains some bacteria which prevents the infection without antibiotic. You see, these are very, very common fractures. Angulation, you apply 2 needles, it is straight. And then you see, because joint is not trespassed, so patient is allowed to move the finger. All the joints, upper and lower, they are free. They are not trespassed, they are not infected, and the wound heals within few days. And just 21 days is the usual time I keep the body needle in case patient is not anemic or not. As I have told you previously, Delayed healing is seen in 3 conditions in India. Number 1 is diabetes. Number 2 is smoking and tobacco. And number 3 is iron deficiency. Maybe anemia or not, but iron deficiency reduces those enzymes responsible for healing. So if you test ferritin and a patient is hemoglobin deficient, then definitely he is anemic and iron deficient as well. So if these 3 conditions do not exist, you don't develop delayed wound healing, delayed bone healing, or delayed soft tissue healing. So this is quite a, see, mutilated finger you can see. And fracture has been stabilized. This is the same case. And after a few days, I applied the strap. At that time, I was not knowing I can staple the fingers also. This is the old case. And you see, after 3-4 days, the wound is almost healed. And this will be a scarless wound later on. You can see this is quite mutilated finger. And again, the same thing has been applied to this girl. And this has totally recovered. Virtually mutilated finger restores without amputation danger. And of course, if tendon is cut, I put it to repair for later on. And this is another very, very good application for the needle. We are very commonly seeing in children as avulsed medial epicondyle. There is no need to go to OT. Just take him to the X-ray or C-arm. By thumb pressure, reduce this and go needle right into the bone and leave it for 3 weeks only and apply a small plaster. So this is totally non-invasive technique. Just beware that you are not entering the ulnar arm. This is very common. I have used in about a dozen cases. It's very safe and very stable one with the flexion plaster. And you can see in this the holding of the skin is without tension. There is no pressure in between. So the wound is good and there is no scar formation. Skin closure scarless. The razor sharp bevel is atraumatic. No tissue compression. No noose-like. Noose is a funda. No noose-like effect of sutures that gives a circular avascular zone. Good from day one, no dressing. This is a video. You can see the movement. Here allowed right from day one. And you see how comfortably he is talking on the phone while he is moving. And it is only day 2. Micro-invasion is safe and effective. This is some old one because the whole needle is there. I have not cut place fracture very finely. Injury. You can see this person is a cane juice expeller. He had a machine and he put his hand into the cane expeller and there was quite a mutilating damage. Then I applied same staples here after a few days, and this is on day 7. And on day 11, wound is almost healed, and he resumed his work on day 15. So after the staple removal, he returns to work. Key to recover in crush injury is to revive vascularity by not applying needle staple, which in center keeps vascular channel open. Thread suturing cuts the remaining blood supply, and thread also by pressure cuts the skin also. They reduce the chances of flash survival. In hand, never do debridement of skin. This is the wrong thing being taught to orthopedician, that debride. Whatever you feel like that, you debride. Wrong. You can debride only on the abdomen, where ample skin and ample substance is available. I have read all these things from Deepama's book, which always say save every millimeter of hand skin, because hand is supplied by a highly specialized nerve plexus, which you cannot get better when you cut the skin. Whatever skin or scar grows, it will not give the same sensation again. So in hand, never do debridement. You just wash it up, more any skin. Skin has highly specialized innervation, so much need aphorism is there in hand and debride, but do not cut skin. And in
Dr. Diwakar, your audio is gone and your screen share is also gone. I think your connection is still
so
slow.
skin has got in body elsewhere else than.
Dr. Diwakar, your screen share has gone.
But I can hear you.
You can hear me. Wait, I think I know.
Can you hear me?
We can hear you.
It's showing slow connection.
No,
Yeah, I can hear you.
I will share my
Yes,
screen. You just do the
you
talking.
continue.
You have some issues there. I will share my screen and you just do the talking.
Can you hear me?
Wait. Now let me start playing them. 1, 2, 3, 4, 5.
I think you can't hear me also.
Yeah, okay.
ड्यूटी बंद करो पूरी बोलो
किसी की होने पहले अतला अंदर सोवे नदियों में
चलाओ उंगली चलाओ
So you can see here that movements are very good.
Can you hear me?
Yes, we can hear you.
The connection is resumed.
Yes. You don't need to share the screen. I will do the share screening. Oh. Correct. Okay. From current slide, yes.
So in my opinion, minimal debridement limited to the freshening of edges only is apt, but in hand save even that. There's no freshening of skin allowed in hand. If constricting suture not used, it will survive. Hence the needle technique combined with the tap water washes, no dressing, and antibiotic on day 1 only. As all antibiotic except macrolide group are powerful immunosuppressant. They can allow resistant flora to bloom. Use portal block or safe opioid or paracetamol for the pain, as they too hamper regeneration, because NSAID they hamper regeneration. Except only in a simple innervation. My method well tested during my graduation time. Nothing is better than this book. This is Deep Palmer. Can you hear me?
We can hear you. Yes.
Can you hear me?
Yes, we can hear you.
Yes. Yes. So this is the book, Deep Palmer's. It is looking very small book, but it is a very long book. More here. This is Palmer's book. This book, this discloses basic secrets of hand surgery. I think this is all. This is the last bouquet which my granddaughter has made for me. तुम्हारा भी खत्म हो गया हमारे ख्याल से.
Good, you can stop sharing screen. Good. Yes. One minute. Let me cover this. Let me cover this. So now we can see that we are sorry to have the interruptions because of slower net correction, and subsequent lectures we will ensure that this problem doesn't come. I will eventually make a proper editing, and on that editing I will correct all the mishaps and post it on YouTube with a link. Dr. Diwakar, can you hear me? Dr. Diwakar,
Yes,
can you
yes.
hear me?
Now it is again resumed.
Now, are there
Yes,
any
I can hear you.
questions? You can either type them or you can
If you
unmute and ask.
have any questions, you can ask. Are there any questions?
Any questions? You can either ask them in
You can
text
unmute
or unmute and ask.
yourself.
Sir, can I ask one question?
Either inbox.
Yes, please go ahead. Go ahead.
Sir, how you bend the needle and how you remove the staple?
Well, you need to have straight artery forceps.
Staple is removed simply by Then the one thing is there. How do I remove it? You just cut the ball of the and the needle can be pulled right now. You cut the ball of the olive plastic bead. You cut the bead and that point needle is straight and it can be pulled from the other end. You just cut the bead only. That's all.
And to bend it, you just hold it on artery forceps and bend it.
I store many needles already cut from the bead.
Well, I think again, Dr. Diwakar has gone. Yes, he's come back again. Come back again. Very good. Add spotlight. Good enough. Question for you is how to repair associated tendon injuries.
In children, you simply approximate and they unite.
In adults?
But in adults, I keep it for later on. It is secondary surgery.
Okay. Second question.
Initially,
Continuous
heal because
insertion of needle creates a gap through which the flora can creep inside the tissue.
yes.
In what way he says needle is also opening and communicating from the superficial
So
to
needle is not having a capillary structure. Capillary structure, it sucks the skin solutions, sweat, and other fluid from outside to inside, taking bacteria along with it. Perhaps you must have seen whenever in suturing you invert the skin, severe infection occurs. Because the macerated skin, it provides the very good culture media and severe infection which is resistant to many things. Yeah, you can wash with the normal saline also. There was you can read on the web that normal saline is also as good, but tap water is as equal to the normal saline or sterilized water. But tap water is definitely better than betadine or other antiseptic solution. We think it is good, but tap water provides you some bacteria which are flora which are non-pathogenic flora. They colonize the wound and they don't allow pathogen to develop.
The question is,
has been used. This method has been used in children. I have used this method and 50% finger survive. I have joined. Suppose patient is having 4 fingers cut, and that if less than half of the bone is cut, the pulp always survive in children, but never in adult. In children, If the half or less of the bone is cut, then amputation survive.
Now the question, one more asks, can this be used as a routine suture in all
And suppose-
orthopedic patients?
Yes, it can be used in surgery also. I have been using same. Why should I store thread and needle and hold some needle holder? I simply have syringe as a driver and needle as a thread material. Always safe and very good and inexpensive.
Can this method be used in complete finger amputation?
Next question.
Can this method be used in complete finger
Yes,
amputation?
and used in children when the half of the palm is cut, half of it. Yes, it can be used.
Now, this question I will answer by showing
Because in most cases, microvascular surgery.
I'll answer by showing some screen shares. This has been recently posted on the net by one of our friends from Nepal about one finger which is fully amputated and another finger which is partially amputated. And I'm going to share my screen and one by one open those pictures to you so that you can see how they behave and how beautifully this system works. So it's not a slide presentation, but just sharing screen and showing 6 pictures to you in sequence. So the first picture is this. You can see that is the amputated finger. Second picture is this, which is in the operation theater. You can see one finger is fully cut, other finger is half cut, and there he has been taken up for a procedure. Now, what has been done in the OT is this, using multiple olives. The complete amputation part has been put back and the partially amputated part is realigned and olived. And there is the thing after cleaning. And this is it. In 4 days' time, you can see that the thing is still surviving and the patient is encouraged to do active movements. So this needle opens possibilities of a revolutionary kind which was not hitherto available to us by other methods. I hope it is clear enough. I will be obliged if you can demonstrate the method and bending in your YouTube link. Yes, I will ask Dr. Diwaker to send me a video and we shall add it to this talk and put it on the YouTube link. Okay, Dr. Diwaker.
Thank you so much.
Thank you all very much.
So I think if you have some question, you can answer.
If you have any more questions, you can
ask the question directly to my inbox, or you can put it to the group. The answer will be there. I'll put a video also.
Thank you very much.
I'll put a video and send it to Dr. Prakash. He will get into the.
Thank you very much for patient hearing and attention. We have been almost able to answer all questions and this talk went off wonderfully well despite multiple interruptions. So what I will do is I will edit it properly, cut away all the interruptions, make it as a crisp and concise talk and upload it on YouTube. Same time on every Sunday, we plan to get one experienced surgeon from India to speak on his lifetime's experience of 30 to 40 years experience in doing many things. We will have Dr. N.K. Maggu from Delhi speaking on preserving hip. We'll have Dr. Arup Mukherjee speaking on rheumatoid arthritis and medical management. We'll have Shiv Shankar, the president of Indian Orthopedic Association, speaking on his 35 years experience in treating intertrochanteric fractures. We'll have Dr. P. N. V.S.V. Prasad from Khammam giving us another wonderful lecture on Jugaad in orthopedics. We'll have Dr. Kiran Patel from Gujarat, who will speak on my 25 years experience with circular and other fixators. So we have got a series of about 15 unusual talks, all on coming Sundays at 8 a.m. If you are not a member of the Indian Academy of Orthopedic Surgeons, I request you all to become a member so that we support in academic, non-commercial orthopedics in making orthopedics popular. Thank you all. Have a nice Sunday. Have a good day. Thanks.